So to him that has will, ways are not wanting. In 1640, that was the original way. Where there's a will, there's a way. So you made the mistake of inviting me and giving me a podium, so I'm going to start with the will part, which is contemporary renal cortical neoplasm practice and the rest of the world, and why appropriate biopsy is important. And then the way, which is probably what a few of you want to hear. Currently, if we were in a standard room, about 93% of you would not be biopsying because it will not change your management, of course, and I'm just going to address that. And then way, we've been doing this in the office. The folks over at Hopkins and LIJ are also doing it in the office. It works really nicely, and we've learned a few little lessons that I could teach you in less than 10 minutes. We'll talk about the equipment. And what I've realized is people want to know if they can bill and collect for it, so I'll just show you our results. So you all know we're seeing a lot more incidental renal masses with a lot more treatment. I think you're all familiar with these statistics, that a fair number of these are actually benign after we've excised them. And that means that about 6,000 people just here in the United States are getting what I will classify as completely unnecessary surgery. You may argue at that statement. This is not a debate or a controversy in any other field for any other tumor in any other organ in any other planet anywhere else. If there's a tumor, you biopsy it before you treat it. It is only a cultural issue in urology. I need people to process that because I can't win a debate on data when it's a cultural issue. I will share some data. This is data that was presented here at the AUA. It just won Best Poster Award in its session. And it just shows you how renal biopsy, which I'll highlight in red, compares to all the other biopsies on the planet. It is extremely effective. It's accurate. It's sensitive. It's specific. It has a low complication rate. If you miss a biopsy, you just repeat the biopsy, and we don't do that many if you look at the number of biopsies in the literature and other fields. So, being that this is a cultural battle, I'll just keep repeating this until it enters the culture. So why would most of you tell me that you don't biopsy? Because it's not going to change your management. Well, if I don't want it to change my management, it will not change my management. But let's talk about why it does. So here's just some data that Ralph Klayman put together, surveyed 6,000 urologists, about 1,100 responses. 68% said the reason they don't biopsy is because it doesn't change management. There's only one piece of data currently published in the world. It just came out. Tony Finelli published this in 2018, Journal of Urology. There were 3 Canadian centers. It wasn't biopsy versus no biopsy. 3 that tended to biopsy versus those that tended not to biopsy, and you can see the results over there at the bottom. The percentage of tumors that underwent unnecessary surgery was 11% overall, but only 5% in those that did tend to biopsy, and 16% in those that didn't biopsy, and that's better than most of the results in the US. They also had, in those 2 places that tended to biopsy, 40% active surveillance. So I understand this will diminish your business a bit, but it's probably the right thing to do. So moving forward with the will part that you didn't want to hear, you can wake up now if you're interested in office biopsy, because this is just the way. This is just an 80-year-old. Usually we're talking about T1As here. I'm not going to biopsy T1Bs or bigger tumors, but this guy happens to be a T1B because that's the day that we hired the videographer to make this video for you. This just happens to be a standard CT. There's no tricks. You'll see at the bottom of the left kidney is a pretty typical renal cortical neoplasm. It's about 5 centimeters. There's a big red arrow in case you're bleary-eyed. And that's actually what we're after. Now, this guy was 80 and he had multiple comorbidities. And quite frankly, the only reason I'm biopsying it is because I would encourage him to possibly even just actively surveil, because he's pretty sick. He didn't have a whole lot of life expectancy. And we have data on T1B active surveillance, but he wanted to know what it was. So the real question is, who do we actually biopsy? And you may not think that this is a regular policy, but anyone who wants an active intervention, be that a cryoablation, a partial nephrectomy, or anything else, they need a biopsy. Because I don't want to take care and put people at risk for a tumor that is benign, or perhaps for an indolent cancer that doesn't need treatment in an older and sicker patient. Who doesn't need biopsy? Well, somebody who just wants active surveillance, so we can just actively surveil them. And those people who are on the fence after you talk to them, I don't know if I want active surveillance. Well, let's find out what kind of tumor you have so you can make an informed decision. The other issue is who am I going to do in the office versus who do I do in the hospital with IR? And the truth is that you mature like anything else. Initially, I just wanted to get this off the ground and do them, and I had a very high indeterminate biopsy rate. But now I do people who I can really easily see on the ultrasound. So generally not upper pole, very anterior tumors. Skin to tumor distance, the farther away it is from the skin, the higher the probability you're going to miss it. So this is the way we start. Somebody comes into your office, they have an incidentally discovered T1A renal cortical neoplasm. Just talk about the need to biopsy. And like I said, if I'm going to do an active intervention, I'm going to biopsy them. Give them information. I have a pamphlet. If you want a copy of it, you can print it out for yourself. You'll notice that he has a rectangle on his flank. So I did an ultrasound to make sure I could see the kidney and the tumor and that the pathway was pretty clear. And I mark his flank. I give him the marking pen, and I said, come back at my next office hours, which is actually a week later, and we're going to do the biopsy. I also give him a prescription for EMLA cream. Believe it or not, this stuff is magical in this setting, because you'll see our pain results, which are bona fide. They're prospectively collected. They're almost nothing if you do it with this technique. Then 1 week later, the patient comes in. The man magically turned into a woman just a week later, which is very unusual. But I'll show you how to set up the tray properly. You don't really need much in the way of an assistant, but it's nice to have somebody. We do the procedure, and an hour later, they come in. This is the setup tray. Anyone who wants this, I'll just send it to you. Just email me. And you can see it's very simple and straightforward. And I'll just play this little video. Largely for this part, this is Ivan, and he's just prepping and draping in what is our standard room. But what I really would like you to pay attention to is the room setup, which is very simple. This is that guy you saw with that 4.9 centimeter mass, and you can see the ultrasound is on the same side as the tumor, which is where I'll be sitting. You make sure that ultrasound is directly in your vision when you got your probe down. You shouldn't be craning your neck around backwards. Just make it nice and practical. A fair bit of jelly. You'll notice in the room I have a lot more help than usual. Again, that's for the video. Make sure I can see it just like I did in the office the week prior. And I see the kidney. At this point, the curve at the top of the screen, there's the skin, obviously. And I'm looking, is there anything between me and the tumor? And the answer is no. There's just some muscles in the back, a little bit of fat, and then you can see the regular kidney parenchyma and the kidney. I can mark it up for you. And then this is the beauty of the system that is now made by Hitachi. They no longer are making the system we're using, but they're coming out with one. Pretty much every ultrasound company has a little guide that you can strap onto the side. I happen to like this one largely because it goes through the transducer, and it made it pretty brainless for me. But I can't do freehand. It's too hard. Tom Chi says it's easy. I just can't figure it out quite yet. But the needle goes through the transducer like that, and just like when you're doing a prostate biopsy, it tees it up for you perfectly. So the alignment isn't perfect of the needle on that little dotted line, but it's pretty close. So you'll notice the first thing I'm doing is taking a spinal needle, and the beauty of having that tract in the spinal needle is you can not only anesthetize the skin, but every millimeter all the way down to the capsule of the tumor, and you'll see in a second I do that, and then leave a little bleb on the skin so that even though he's got EMLA, I'm going to make that bleb, the needle all the way down, and then I'm going to just take an 11 blade and make a tiny incision. And of course, that's what will make all the blood for this case, which is pretty nominal. The incision shouldn't be super tiny. I just find it hard to get the needle in there, especially if you're doing this alone, which usually you are. That's the hardest part of the case, is getting the needle through the transducer. You can find that little, line it up there. And then you're just going to do it just like you would a prostate, except you're not going through the rectum, of course. You'll line it up in the flank. You see how quick that is, and people who come to visit us are actually always disappointed because this whole thing that I'm showing you here literally takes 3 or 4 minutes for the whole biopsy, and then we're done. How many cores do you want to take? I think it depends on the quality of your cores, but our average is about 3 or 4. And then that's pretty much it. An hour later, I'll put on a little dressing. About an hour later, what I'm going to do is just repeat the ultrasound. If there's no hematoma around the kidney, I'm sending him home, and I'll show you the results now. Good. So we very carefully choose appropriate candidates, those that we see in the office where the pathway is easy. If you have somebody who has to come off anticoagulation, when you come off anticoagulation, you're at higher risk for a coagulopathic event. These are people who are in the office, and you don't want to have to rush them off to the hospital, so just we're careful. Also people where it's going to alter management, which is pretty much anyone who's going to have intervention. Who do we exclude? Upper pole tumors, long skin to tumor distance, and these people who have lots of comorbidities. You can see the characteristics of our patients right there. We've only done about 52. Median age is what you would expect. BMI is skinny, because I'll send the really challenging cases to IR. Men and women, half and half. Here's the mean size. These are largely T1As, and what you'll notice is that I don't do a whole lot of upper poles anymore, because those are the ones I was missing, and those are challenging. The key here is that somewhere around 20% are benign, and another 20% are indolent tumors in older, sicker people. So overall, we get about 40% of people going to active surveillance. But the ones where we have had some intervention and we have final histopathology, it's incredibly accurate, and you can see the results there. So where do our patients go? Largely, they go to all the different modalities, partial nephrectomy, but look at that, 40% are going to active surveillance, which is exactly what Tony Finelli showed us in Canada with good use of biopsy. Complications, that's my favorite part. I think because the patient's awake and they're not moving, you just poke the needle in and out, so you're not dragging the needle along the surface of the kidney. We've had no complications so far, we'll knock on wood. And the pain, look at that, that is remarkably low. Sorry. Let's go back to that. Why is that? The Emla cream makes the skin intervention almost nothing, and then using that spinal needle to get the lidocaine all the way down the path, all the way to the capsule, really helps. So billing and collecting, and I'm happy to share, this is just what we've got. We have a site of service 11, that means it's not hospital owned, and you could make a few bucks for your initial visit and the ultrasound in the office, and then we do the standard biopsy, and you can bill and collect for those two, and depending on your insurance distribution, you will be paid in a manner similar to this, I'm sure. So in conclusion, finding the will, I don't think I'll convince many of you, but I really feel it's important that we be at least as good as all the other surgeons on the planet who treat tumors. Careful patient selection is something I've learned, so I'm doing less of these. I send a fair bit to interventional radiology, but you know, one or two a week we can certainly do. No radiation because it's ultrasound. No sedation. They just get local. Negligible discomfort, minimal narcotics, and they're back to activity in a day or two. And we do get accurate results. And it eliminates the unnecessary surgery. We literally have a 0% incidence of benign tumors for T1A renal cortical neoplasms at UCI now. And that's it. Thank you.